For decades, the gold standard for treating endometriosis has relied on a straightforward mechanical approach: suppress the disease with hormones and use surgical excision to physically remove ectopic lesions from the pelvic cavity. This strategy effectively controls the physical spread of the tissue. Yet, for a significant number of patients, it fails to provide durable relief from chronic pelvic pain. The clinical presentation often contradicts the physical pathology. A patient might have a high concentration of lesions strictly on the right side of her pelvis, while her most intense, debilitating pain radiates entirely across the left side and lower back. Between 71 and 87% of women with chronic pelvic pain have laparoscopically proven endometriosis. However, the specific locations of those physical lesions correlate poorly with the areas where patients experience their worst pain. Even after a surgeon meticulously removes every visible trace of ectopic tissue, post-surgical pain mapping frequently reveals a separate pattern of affliction, one that persists long after the initial surgical wounds have healed. Chronic pelvic pain and endometriosis cannot be strictly a localized visceral problem. The persistence of symptoms indicates that a secondary, hidden architecture of pain is actively operating. Ectopic lesions operate as biological instigators, triggering a cascading neuroinflammatory response throughout the surrounding tissue. The true architecture of the pain shifts from the local organs themselves to the broader nervous system. This shift is driven by central sensitization. Under continuous distress, the central nervous system undergoes structural and functional rearrangements. It lowers its threshold for activation, meaning a central spinal hub that receives a pain signal remains continuously active, even after the peripheral trigger stops firing. This central neuroplasticity causes the perception of pain to expand outward, hijacking nerve pathways that supply distant, otherwise entirely healthy regions of the pelvis. Surgically removing the ectopic lesion addresses the initial spark, but if central sensitization has taken hold, treating the lesion alone ignores the fire actively burning within the central nervous system. To survive outside the uterus, ectopic endometrial tissue must establish a blood supply, forcing a branching network of new blood vessels into the abnormal cells. The creation of this vascular network establishes a physical pathway for the invasion of new nerve fibers. The lesions secrete high levels of nerve growth factor, or NGF. This molecule binds to local C-fiber nociceptors, the sensory nerves responsible for transmitting pain. The NGF forces these nerve fibers to elongate and weave directly into the endometrial tissue itself. At the same time, the peritoneal fluid surrounding these growths is highly inflammatory, saturated with active immune cells like macrophages, alongside interleukins and prostaglandins. Continuous exposure to this aggressive immune soup actively lowers the activation threshold of these newly sprouted nociceptors. A state of peripheral sensitization sets in, causing the nerves to fire off pain signals at the slightest provocation. The lesion effectively hardwires itself into the host's nervous system, building an amplified, hypersensitive alarm bell right in the periphery. This neuroanatomical diagram illustrates exactly how these newly sensitized peripheral nerves map back to the central nervous system. The continuous nociceptive bombardment from the lesion follows this pathway, traveling upward and entering the dorsal horn of the sacral spine. Once inside the spinal cord, these signals hit a critical anatomical bottleneck. Visceral afferent fibers, the nerves coming from internal organs, make up only 2 to 7% of all spinal inputs. Because they are so heavily outnumbered, the visceral nociceptors must synapse onto the exact same spinal interneurons as the somatic nociceptors coming from the skin and skeletal muscle. This structural reality is known as viscerosomatic convergence. This shared circuitry forces two distinct pain signals to use a single communication line.
The brain receives the distress call but cannot precisely localize the source, resulting in referred pain, where organ dysfunction is felt intensely in the surrounding pelvic muscles. To compound the issue, visceral afferent fibers do not terminate at a single point. The incoming nerve branches out, sending signals across multiple spinal segments above and below its primary entry point, spreading the hyperexcitability. Viscerosomatic convergence explains how a highly localized visceral lesion can hijack multiple areas of the spinal cord, broadcasting severe pain to entirely different organ systems and muscle groups. This central integration of pain signals generates a second consequence known as the viscerosomatic reflex. Looking closely at the cross-section of the pelvic floor, we see that those hyperactive spinal interneurons inadvertently trigger alpha and gamma motor neurons, which send an action potential right back to the skeletal muscles. These heightened sacral reflexes force the pelvic floor muscles, specifically the levator ani and sphincter ani, into a state of sustained hypertonicity and constant spasm. This constant mechanical strain leads to the formation of myofascial trigger points, or MTRPs. These are palpable, hyper-irritable nodules that develop along the taut, overworked bands of skeletal muscle. Active myofascial trigger points complicate the clinical picture. They begin to secrete their own pro-inflammatory neuropeptides, serving as a distinct source of ongoing nociceptive input. The trigger points act as autonomous pain generators. They actively sustain central sensitization and chronic pelvic pain, even if surgery has completely eradicated the initial endometrial disease. Because the pain architecture has physically expanded from the viscera into the musculoskeletal system, standard gynecological exams will completely miss the active pain generators. To properly assess this dysfunction, the standard bimanual exam must be replaced with a targeted, single-digit neuromusculoskeletal exam, isolating the internal bands of the obturator internus and levator ani. Clinicians must evaluate the patient's dermatomes for allodynia, the sensation of pain from non-noxious stimuli, and hyperalgesia. The presence of either serves as clinical proof of central sensitization. By palpating the pelvic floor slowly, the examiner can isolate specific taut muscle bands to confirm if applying pressure reproduces the patient's exact chronic pain symptoms. Evaluating endometriosis without simultaneously assessing for myofascial dysfunction leaves the most enduring component of the patient's chronic pain entirely undiagnosed. Standard hormonal therapies and laparoscopic excision target the ectopic tissue, but they cannot deactivate an autonomous, hypercontracted myofascial trigger point. This requires a targeted neuromuscular intervention. Botulinum toxin type A, typically utilized for focal dystonias, provides a mechanism to break this specific viscerosomatic loop. This data table outlines the clinical efficacy of this approach. Reviewing the outcomes across multiple trials demonstrates that targeted injections yield consistent reductions in resting pelvic floor pressure, dyspareunia, and non-menstrual pelvic pain. The toxin works through a dual mechanism. First, it blocks acetylcholine release at the neuromuscular junction, forcing hypercontracted pelvic muscles to relax. Second, it provides direct analgesia by altering intracellular trafficking, preventing the release of pro-inflammatory neuropeptides from nociceptor terminals. This dual-action intervention physically dismantles the trigger point while simultaneously starving the central sensitization loop of its peripheral noxious input. While the local effects last 3 to 6 months and require re-injection, this period of profound muscle relaxation and sensory blockade gives the central nervous system the critical opportunity to reverse its maladaptive changes. Resolving endometriosis-associated chronic pelvic pain requires moving beyond the lesion. It demands treating the entire viscerosomatic network, integrating traditional surgical management with